really about disease management approaches. We started talking about cardiometabolic diseases around. I remember the first conference in Nairobi, 2004, which I mentioned, cardiometabolic diseases. I just wondered, this was important with doctors from Mauritius and Nairobi. It was a small conference where the Grand Regions then, and I think we were exploring at the time the link between diabetes, heart disease, and discussed. And I think a lot has become clear. I know we're going to hear a lot about this. One of my favorites is the Revolution Flat. The World Flat Footed. It's a lovely example. They were trying to just play safe. There was a greater somewhere. Was glitazone, which is a good diabetes drug, we then mandated to any diabetes drug coming out had to show that at worst it was safe and didn't cause too much trouble on the cardiac front. To their surprise, they found that in fact there was a reduction in cardiovascular death and all-cause mortality. Heart failure hospitalization in numbers that we have not seen since the ACE inhibitor trials and the sacubitril valsartan trials. And then, as a bystander, that kidney disease progression was slowed down and new kidney disease diagnosis was slowed down. And I think cardiologists were kind of opportunists came on, and we're now calling this our own. So it's a bit of a, it was maybe initially a bit of a tug of war, but I think we realized we're in the same camp. And that's why we're here with renal specialists. And the science behind this, I think, as we were doing our work 30 years ago, one Japanese fellow was actually in the lab, banging the midnight oil, trying to find out how fluorescence can be used in treating diabetes. And they managed to convert what was a parental agent to an oral agent. And therefore found that it reduces glucose levels bypassing insulin mechanisms. And I think that discovery, I'm not sure they realize exactly what they've done, but that's what's now snowballed into literally a molecule now that we can use across the spectrum of diseases that encompass the cardio-metabolic diseases. So as we look at what we're going to be told today, I think let's keep in mind that we are merely part of the same family, different continents, different races. I'm talking about the diseases, but we must remember that when you impact one, it's like skittles, you impact the next. If you ignore the kidney disease, you are welcoming heart problems. If you ignore the heart problem, welcoming renal disease. If you ignore heart failure, then you're welcoming the other diseases. So I hope I've convinced you that our presence is relevant. And with this, I have great pleasure in inviting Sahula, who is a very prominent kidney worker at UCL London. I think you're based at Royal Free now as well, and you've been the past chair of the KBIGO Society and the guideline committees. And I think I saw that your research interest is on the manifestation of cardiovascular diseases in chronic hemophilia. So I think they brought the right gentleman to take us through. So without much more ado, I invite you.
Well, thank you very much, Charles, for that very kind introduction. This is all about working together. And certainly the patients that I look after now in London don't just have kidney disease, they also have diabetes, and they also have heart failure, and they also have peripheral vascular disease. They come with a range of diseases now. And I increasingly find myself having to ask my colleagues to help me manage these multiple diseases. And I'm trying to learn quickly myself what the right drugs are, not just for the nephrology side, it's not just for the kidneys, but for all the other problems that these patients have. So this is us working together. And these drugs have brought us together because we all want to use them, because the patients we see need these drugs. So that's what this is about. So I'm a nephrologist. I came to Kenya first time during my what we call elective period. We were allowed at university to have 1 month in a different country, and I chose to come to Kenya. And I remember I worked at a little missionary hospital called Kijabi, which is on the edge of the Rift Valley, way out of Nairobi. And I was allowed for the first time to be on call and to have a bleep. Even though I was still a student, I was given that responsibility, and I had such a good time there and learned so much medicine. So I have fond memories of Kenya. I've been back a couple of times since, but thank you very much for having me back today. I look after patients with chronic kidney disease. I'm employed by this university, but I work at a local hospital called the Royal Free Hospital, where we have a kidney unit that is managed by 23 nephrologists. We manage around about 1,000 patients on hemodialysis, and we follow up about 2,000 patients who have kidney transplants. So it's a big service. I should just add that my disclosures are in the bottom left-hand corner of the screen. So you've heard this story, in fact, from Charles. This is the success story of SGLT2 inhibitors. This is a timeline of the clinical trials, and there's 13 of them here. And as you heard, these trials started with the mandated cardiovascular safety studies that all the companies had to do to prove that these drugs were safe from the cardiovascular perspective. And you know all the names of these trials, and I'm not going to go through them. But as you've heard already, these trials suggested that not only were these drugs which were developed to treat type 2 diabetes, not only were they safe from the cardiovascular perspective, but they had cardiovascular benefits. And that led to the cardiovascular studies where cardiologists, heart failure specialists took these drugs into patients with heart failure, initially with reduced ejection fraction and then with preserved ejection fraction. And guess what? These drugs improved outcomes in these patients, particularly hospitalizations for heart failure. Now, if that wasn't good enough, the kidney doctors were picking up on this at this stage, because the kidney doctors were noticing some good kidney signals in these trials. They were noticing reductions in albuminuria. They were noting that fewer patients developed the earliest signs of diabetic kidney disease. And they were seeing reductions in patients going on to end-stage stop them developing kidney failure. The trials needed patients to have albumin in their urine. So this is urinary albumin to creatinine ratio. And in my country, we measure this as milligram of albumin per millimole of creatinine. So you're correcting the albumin for the creatinine, the concentration of the urine. And normal in my country is less than 3 milligram per millimole. And you'll see that all these trials have recruited patients with albuminuria. But the Empagliflozin study was the first of these studies to recruit patients who had kidney disease but did not have albumin in their urine. So non-albuminuric chronic kidney disease. And we'll come on to that in just a minute. So let's talk about this trial. And this trial was developed by some mates of mine in Oxford in the United Kingdom. It was supported by Boehringer Ingelheim, but the trial was developed by an academic committee in conjunction with the pharmaceutical company. So this came out of the University of Oxford. And of course, the trial was designed to assess the effects of empagliflozin in a broad range of patients with chronic kidney disease, some of whom had diabetes, but actually most of whom did not have diabetes and therefore did not have diabetic kidney disease. Now, this was quite brave. The team in Oxford who designed this trial wanted to recruit patients who had EGFRs all the way down to 20 mils per minute. Now, that's fairly advanced chronic kidney disease, and many of us felt before this trial that you actually couldn't fix kidneys that were that badly damaged, and that inevitably those kidneys would continue to fail whatever you did. And we now realize that that is wrong, and it is not too late to fix kidneys when EGFRs are 20. So the Empagliflozin trial allowed in patients with EGFRs between 20 and 45, regardless of the level of albumin in their urine. If patients had EGFRs between 45 and 90, they needed to have albuminuria, and you see that that's greater than 200 milligram per gram, 22.6 milligram per millimole in humans use. Now, the trial did exclude patients with polycystic kidney disease and excluded kidney transplant recipients, and we can talk about that. The trial took these patients and randomized them to empagliflozin 10 milligrams once daily or a matched placebo. And this was an event-driven trial, meaning that the investigators monitored the number of events occurring, and the trial was meant to stop when that number of events had been accrued. In fact, the trial was stopped earlier than that, because of the overwhelming efficacy of the drug. And the Data Safety Monitoring Board, who were not blinded to the trial, who monitored the trial, decided that this should be stopped early because patients were benefiting from going on to the drug. Now, the endpoint of this trial is a little bit complicated, and I want to talk you through it. It is the composite of cardiovascular death and kidney disease progression. Now, what is kidney disease progression? Well, in this trial, it was defined as the development of end-stage kidney disease, that's an EGFR of less than 15, the need for dialysis or kidney transplantation, or death of a patient from kidney failure in the absence of dialysis or kidney transplantation. Also in that kidney disease progression endpoint was a reduction in EGFR of 40% from the baseline value, or a reduction of EGFR to less than 10 mil per minute per 1.73 meters squared. So there's lots of kidney events in there, some early events like reductions in EGFR, and some late events like the need for dialysis, kidney transplantation, or death due to kidney disease. So 6,609 patients recruited from many different countries around the world. These were randomized, as you can see, to empagliflozin or placebo in a double-blind trial. And they were followed up over time. A few patients dropped out along the way, but actually retention of patients in the study was very good. And the median follow-up time in the study was around about 2 months. So if you've done your randomization properly in a trial, you get a really nice balance between the two groups. And that's exactly what you see here. So 304 patients were randomized to empagliflozin, 305 patients to the placebo. This was on the background of standard care for these patients. And standard care for these patients includes the use of ACEs or ARBs, angiotensin receptor blockers, when at all possible, good blood pressure control, good glycemic control, healthy lifestyle, and so on. So on top of that background therapy, these patients were randomized to empagliflozin. You can see there the groups are very well balanced in terms of age, gender, the percentage with prior diabetes. We'll come back to that. Starting EGFR, starting median urinary albumin to creatinine ratio, and non-diabetic causes of chronic kidney disease. So you will have some patients there who have diabetes, but have other non-diabetic causes of chronic kidney disease. So 2/3 of patients didn't have diabetic kidney disease. So this was the outcome, the primary outcome, and I've just put the placebo on here to start with. You're looking at a Kaplan-Meier plot of events occurring over time during the study. So you can see their years of follow-up. In the placebo group, 558 of those events occurred during this 2.5-year, just over 2-year follow-up period. And then here we have the empagliflozin group, those patients randomized to empagliflozin. And you can see here a clear reduction in those events during the study. And this is 28% reduction, which gives you a hazard ratio of 0.72. The confidence intervals do not cross 1, 0.64 to 0.82, meaning this is a statistically significant reduction in the occurrence of these endpoints in those patients randomized to empagliflozin. And if you like p-values, you can see all of those noughts in the p-value, meaning this is highly statistically significant. So this was good news for patients. Remember that that primary outcome was a composite of kidney events and cardiovascular. If we look at the two components of that composite, the kidney disease progression events were significantly lower. We didn't see such a clear reduction in the cardiovascular death events. In fact, there wasn't a reduction in the cardiovascular death events. You can see their confidence intervals crossing 1, meaning this is not statistically significant, and you can see no difference in the Kaplan-Meier plot. Now, Charles mentioned the Empagliflozin study in which there was actually a reduction. And so why are we not seeing that here? Well, this is a much shorter trial, and these patients are probably at lower risk of cardiovascular death than the patients who went into the Empagliflozin study. The endpoint here is driven by the kidney disease progression rather than the reductions in cardiovascular death during the trial. Now, did it matter whether or not the patients had type 2 diabetes? And I just want to talk you through this forest plot. So you have here, my pointer doesn't work, but in the open diamond here, you can see the overall results of the trial that I've just shown you. It falls to the left of 1, the null effect, meaning this is a statistically significant 28% reduction, as I've told you already. Now, if you ask, did it matter if the patients had diabetes or not, you can see there the subgroups of patients who went into the trial with diabetes and without diabetes. You've got the numbers of events over the numbers of patients on the left-hand side there, and the hazard ratios on the right-hand side. What you can see there is for both diabetic and non-diabetic patients, there was a significant reduction in these endpoints favoring empagliflozin. explore using these drugs even lower levels of inflammation. Our license in the UK for empagliflozin is 20 to 90 as the criteria for the trial. Did it matter what the baseline level of albumin in the urine was? And this is slightly more complicated. If you look at this here, you're looking at that same kind of plot with patients divided up according to the baseline level of albumin in their urine. Now, this is urinary albumin to creatinine ratio, UACR, in milligram per gram, the American unit. So normal is less than 30. So this top line has no albumin in their urine. Then you've got 30 to 300, then you've got 300, and then you've got the overall result of the trial. You'll see here a suggestion that those patients who have less albumin actually gain less benefits from randomization to the drug. The point estimate for the patients with albumin levels less than 30 is actually right on that line of another effect, suggesting a neutral effect. So for the overall outcome of the trial, that overall primary outcome, didn't see a clear benefit in those who had levels of albuminuria that were in the normal range when patients went in. But I'm going to show you something else in a minute to suggest that actually those patients were gaining some benefit. It's just not clear from this analysis of the primary. Before I do that, I want to show you what happened to eGFR slope. So this is kidney function, estimated GFR, over time in the study in the placebo group. You can see here months of the trial on the x-axis, eGFR on the y-axis, and there's some numbers there. The numbers give you the slope of the eGFR decline in mil per minute to 1.7 years. It's loss of kidney function. Now, as I'm standing here, I'm losing a mil per minute per 1.73 meters squared of my eGFR because I'm over 55. So we all lose a little bit of kidney function over time as we get older, but we shouldn't drop below an eGFR of 60. These patients on placebo in the trial are losing kidney function at 3 times that rate that we associate with normal aging. And you can see here a relentless reduction in eGFR during the trial. What happens to those randomized to empagliflozin? There was a 2-month blood sample that was taken from the vast majority of patients recruited into this trial and analyzed in a central laboratory. And here you see this drop in eGFR at 2 months. Now let's just think about this. We want to make kidneys better, but putting patients on this drug that actually initially makes kidney function worse is a drop in eGFR. What happens after that is the subsequent rate of decline of eGFR is not so steep. These patients are losing eGFR at 1.37 mil per minute per year, which is a little bit faster than normal aging, but much slower than those patients on the placebo. And if you look at the difference between the two, the difference is also 1.37 mil per minute to 1.73 meters squared. Now, if you're losing kidney function more slowly, it means you will have more kidney function for longer, and you are less likely to reach kidney failure during your lifetime. So this is a reset. The initial drop, we believe, is a change in the pressure in the glomerulus, a reduction in pressure in the glomerulus, the filters in the kidney. They depressurize, they work a little bit less hard, they filter a little bit less, but in the longer term, that is a protective mechanism because they're working at a lower pressure and they last longer. And this drop in eGFR has been seen with all drugs pretty much that are kidney protective. We see this with ACEs and ARBs. We see this with SGLT2s. We're seeing this with some of the mineralocorticoid receptor antagonists. This is a feature of a kidney protective drug. You will lose a bit of kidney function. You will then have a slower rate of decline in kidney function subsequently. And if you take patients off these drugs, they actually regain that little bit of kidney function that they lost at the beginning. So that's a reversible change in kidney function. So now back to the albuminuria, because this is where I want to go back to the eGFR slopes and look at the slopes, the eGFR declines in patients with different levels of albuminuria. So bear with me. This is slightly painful. This is the rate of decline of EGFR in patients with those different levels of albuminuria who are randomized to placebo. So you'll see there no albuminuria declining at 0.89 mil per minute per year, 30 to 300 at 1.69 mil per minute per year, and greater than 300 at 4 mil per minute per year. Now we know this, that more albumin in a patient's urine, the faster the rate of decline of kidney function, and we're seeing that in this placebo group. Let's look at what happens to the patients with those different levels of albuminuria who are randomized to empagliflozin. Well, you'll see lower numbers, slower declines of kidney function in all those groups when randomized to empagliflozin compared to placebo. So even in those patients who had no albuminuria, less than 30 going into the trial, those with no albuminuria who were randomized to empagliflozin showed a slower rate of decline of kidney function compared to those who had no albuminuria who were randomized to placebo. And you can see all those results line up in the point estimates quite nicely, and all favor empagliflozin in all of those subgroups. What am I saying? I'm saying that in patients who don't have albumin in their urine, there is still a benefit of empagliflozin in slowing the rate of decline of EGFR, meaning that we are protecting patients from the progression of kidney disease and the development of RAAS and the need for kidney replacement therapies. Okay, this is EGFR slopes by diabetes status, and as you might expect, it didn't matter whether the patient was diabetic or not. They still gained benefit in terms of the slowing of the EGFR slopes. Some quite dramatic differences, though, in a type 1 diabetic population there. There weren't many patients with type 1 diabetes getting into this trial. But you can see there the differences in the slopes, regardless of whether the patients had diabetes or not. So randomization to empagliflozin slows progression of kidney function loss in type 2 diabetes, in no diabetes, and also in those few patients who got in with type 1 diabetes. Now, there were a few secondary outcomes in this trial that I just want to talk about. Two of these did not reach statistical significance. That was hospitalization for heart failure or death due to cardiovascular disease. I've shown you some data on cardiovascular disease already. And there was not a reduction in all-cause mortality in those patients randomized to empagliflozin. The trends are there. If you look at the numbers, the p-values are not statistically significant. And I think what happened is this was a fairly well group of patients, and there weren't many of these events in this population, and therefore we're not able to detect a significant difference. Although if you look at the numbers there, you can see that numerically fewer of these events occurred in those on empagliflozin. There was a reduction, a significant reduction in all-cause hospitalization, patients needing to go into hospital. And this is statistically significant. This was one of the three secondary outcomes. So patients randomized to empagliflozin less likely to go into hospital for whatever reason. That must be good for patients. I'm sure we didn't want to go into hospital. So that's the good bit. How about the downside? What's the downside? Well, there isn't really a big downside here. It's not really a major safety issue. Yes, patients on these drugs we out sugar in their urine, and if they're not careful with their genital health, develop genital fungal infections. We've known that for many years. Patients are warned about that when they go onto these drugs, and they're careful. We don't see an increase in urinary tract infection on these drugs. This is a myth. People say, oh, you're going to glycate the urine. There will be more sugar in the urine, more bacteria will grow. These patients will get urosepsis. This does not happen in this trial. When patients don't develop hypovolemia on these drugs. Remember, ACEs and ARBs, which are also kidney protected, drive hypovolemia. See that on this lower levels. Patients randomized. And there's a recent meta-analysis showing a significantly lower level of potassium in patients randomized to these drugs. Remember that drop in EGFR? You might worry about acute kidney injury, acute damage to the kidney. You don't see it. That drop in EGFR is not acute kidney injury. In fact, there were fewer acute kidney injury events in those patients randomized to empagliflozin compared to placebo. It wasn't statistically significant. You can see the confidence intervals just pick one. If you put the data from all these trials together, there's a very consistent picture here. Less acute kidney injury in patients randomized to these groups. Speculate as to why that might be. Ketoacidosis is a small worry. You see the numbers of events there. We've seen this in other trials. These patients can develop ketoacidosis without a high blood sugar because they're weaning out the sugar, and we just need to be aware that in patients, particularly patients who have very low insulin production and levels of insulin production, that there is this risk of ketoacidosis, and we might want to mention that to patients and perhaps equip them with a way of detecting ketoacidosis. Lower limb amputation always worries us with these drugs. We've seen it with some of the other drugs in the class. There's a numerical imbalance there, and as you can see, it's not statistically significant. But we do need to just be aware that in patients with peripheral arterial disease and critical ischemia, these might not be the best drugs to use because of this. So this trial was published in the New England Journal of Medicine, as was the credence in that CKD trial. We now have these 3 trials, all published in the New England Journal of Medicine, demonstrating to us that SGLT2 inhibitors can be kidney protective in patients with and without. I'm going to finish with some guidelines and with a couple of messages around implementation. So you heard that I was co-chair of KDIGO, Kidney Disease Improving Global Outcomes, a few years back. KDIGO is a not-for-profit organization. It's incorporated in Belgium. Its aim is to produce guidelines to help clinicians manage patients and to help decision-making around patient care. KDIGO produces evidence-based guidelines. Before the guidelines are written, there is an evidence review. Evidence is assimilated, it's tested, it's criticized by a group of evidence experts, and the recommendations are then made. This is from the updated 2024 KDIGO Chronic Kidney Disease Management Guidelines. This guideline was initially produced in 2012. No mention of SGLT2 inhibitors in 2012. Here is the 2024 update with 3 recommendations of SGLT2 inhibitors with 1 A-grade evidence rating. This is the highest rating you can give a recommendation in medical practice. This means strong evidence. You should do this. So let's look at them. 3.7.1, we recommend treating patients with type 2 diabetes, CKD, and an EGFR greater than 20, that's the lower limit of the Empagliflozin trial, and with an SGLT2 inhibitor. What a diabetic, they've got kidney disease, they've got an EGFR above 20. You're going to want to treat their diabetes, choose an SGLT2 inhibitor, because you get the added benefit of kidney protection and heart protection. You don't get that before solving. Next recommendation is broader, and it's around kidney disease. We recommend treating adults with chronic kidney disease with an SGLT2 for the following: an EGFR of greater than 20 with a UACR of greater than 200, or heart failure, irrespective of the level of albuminuria. So that, no mention of diabetes there. That's saying if you've got a CKD patient, they've got an EGFR of greater than 20, and they've got albumin in their urine, or if they've got heart failure, regardless of their albumin urine level, prescribe an SGLT2 inhibitor, offer them an SGLT2 inhibitor. And then the third recommendation comes straight from the Empagliflozin trial. It's almost written from the protocol. Adults with an EGFR between 20 to 45 who have a UACR of less than 20 milligram per millimole, that's effectively no albuminuria, treat those individuals with an SGLT2 inhibitor. So that's that group of patients who don't have albuminuria, who I showed you in those forest plots, benefit from a slowing of the rate of decline of their EGFR when randomized to an SGLT2 inhibitor or when treated with an SGLT2 inhibitor. It's a 2B recommendation. The evidence is less strong. It's from one trial, Empagliflozin.
but it's there in the recommendations. Let me talk you through this. This is modeling. And what we're looking at here is what potential benefit you could have on a patient by prescribing empagliflozin. Now, in the bottom left corner of this graph, you've got a patient with a starting eGFR of 20, so right at the bottom of the range, started on empagliflozin in green or not started on empagliflozin in orange. You could argue they went into the trial and they got randomized to one or the other, or you treated them with the drug. It doesn't really matter which. Treatment with empagliflozin slowed down the progression of kidney disease such that the patient got to an eGFR of 10, and that's pretty bad, and that's when we start dialysis in London, got down to an eGFR of 10, 1.9, so 2 years later if they were prescribed empagliflozin. So you can potentially delay that kidney failure by 2 years if you start at an eGFR of 20. But look what you can achieve if you start at an eGFR of 85. So if you look at the other patient at the top there, starting eGFR of 85, let's say they're a diabetic, they've got albumin in their urine, they've got the earliest signs of kidney disease. If you give them empagliflozin, they follow the green line. If you give them placebo, they follow the orange line. Now, these aren't real data. These are generated from the data from the trial. But you can see there potentially a 27-year delay in that patient reaching that very low level of kidney function. So the message here is if you're going to have the maximum impact with these drugs, you've got to find patients with early kidney disease, get them onto these drugs early. And by doing that, you will have a massive impact on the time in their life where they will reach kidney failure. And I would argue that for many people, the average age of our patients developing kidney failure is in their 60s and early 70s. For many of these people, you could actually prevent them developing kidney failure during their life. Now, to do that, we've got to pick up kidney disease early. We've got to find kidney disease in diabetic clinics, in hypertension clinics, in cardiovascular clinics, and so on. And that means collaboration between healthcare professionals. But we do now have the potential to have a massive impact on the rate of decline of kidney function in these patients. So I'm done. EMPA-Kidney, big trial. Chronic kidney disease due to a wide range of causes. Patients who had low levels of kidney function and who didn't have albuminuria were included. Empagliflozin, as I showed you, reduced that kidney endpoint or that composite of kidney disease progression or cardiovascular death by 28%, largely because it reduced the kidney endpoints. The benefits were consistent regardless of the diabetes status, regardless of the starting eGFR. And in that slope analysis, you can see the potential impact that empagliflozin has, even in those patients who don't have albumin in their urine when they start the trial. So I'm going to thank you for listening to me, and I'm going to hand back to our chair for the next part of the meeting. Thank you.
Thank you very much, Prof. I've learned a lot about kidneys I didn't know. I think what we're being told is that that's a 60-year-old patient without albuminuria. So thank you again for attending this session. Doctors will come to us from Mombasa, Kisumu, Ghana, Nigeria, some from as far as Loresho. So I'd wish to welcome the panel, and so that we can discuss this very important subject. And I think we should have had a nutritionist here as well, but I think they spoiled the party, so we elected not to before dinner. So without wasting too much time, I would like to invite Dr. Adan, Real One Adan, from the Lions Eye Center. Let me see. Need to get everything right. Yes.
So she's described in my profile in various ways, but I'll keep it simple. Excellent physician, diabetologist based in Nairobi, and serves as the head of Diabetes Care Center at the Lions site, First Eye Hospital. And what caught my attention is she's the chief medical officer at Baobab Circle. That's a group in the UK that deal with digital health, which I think she's passionate about, and maybe we'll want to hear a little bit about that. And with her strong academic background, she has an MRCP from the UK, master's from Kenya, and I think has gone on to, was it Cardiff? I think it was, for renal medicine. Welcome, welcome. Give her a hand. Yeah. The next person, I was about to say patient, next person I'd like to invite is Professor Boehringer. Have I said it correctly? Good, from Ghana, welcome. Professor Vincent Boehringer is a senior lecturer at the University of Ghana Medical School, consultant nephrologist, and at the teaching hospital, I think it's called Ebu Teaching Hospital, where he heads a renal unit, and a member of the Africa Regional Board for the International Society of Nephrology, and is a fellow of several medical colleges, and focuses on, quite interesting, the psychological well-being of CKD patients, with over 40 publications that have been quite impactful. I think you're also investigating the genetic predispositions to CKD. It would be a bit interesting to hear about. I would like to now also welcome Dr. Amadi, my partner in crime. He's an accomplished cardiologist and is an associate professor of the University of Lagos, a leading figure in cardiovascular research and preventive cardiology. I think you've had a lot of experience in collaborative research, pioneering studies in heart failure, hypertension in Africa. He's not a new face to many of us. I think Prof. Ogola might have worked with him on the heart failure studies and hypertension studies in the continent. I think I noticed you focus on cardiovascular epidemiology, preventive strategies, non-invasive cardiology. Now I'm reading all this out so that I set them up for any questions you may have. I think maybe, did I left anybody out? Wait, I think we're good. Now we're going to address a few questions. I think Dr. Madi may have a video for us at some stage as well. Sorry? No, let's, there's this thing that we must abide to, maybe not, but ladies first. So we'll ask her to comment. But first, maybe we'd like to point out one or two issues or request Professor Wheeler to maybe comment on one or two things. Now, the key recommendations for the use of SGLT2 inhibitors in CKD management, I think you outlined the guidelines very nicely. One of the things we'll be asking you is the penetration of use of these drugs in the pure CKD patient. I don't know if you can come up, please. Do we have a microphone? Yeah. And maybe, yeah, you could try and address that. I've got a couple more for you that just to clarify.
So I can talk about the UK because we've just had our national meeting that I attended before I flew here. And we looked at data on the use of these drugs in the UK. Of patients who are eligible for these drugs in the UK, less than 20% are actually prescribed these drugs. So if you take those patients who were eligible for these drugs according to those guidelines, less than 20% are actually on these drugs. So big gap, big gap. Now those data are a year and a half, 2 years old now. It may be better, but it's nowhere near what it could be in the UK.
Right. I mean, there are very many questions I'm sure that will come for the audience, but just out of interest, these are the European guidelines. What are the other societies saying that may be different from this?
Well, the KDIGO guidelines are often looked upon as global guidelines because the organization is a global organization. Now, local guideline working groups often take the KDIGO recommendations and interpret them themselves and may put a local spin on them. Mm-hmm. But actually, those guidelines should apply internationally. And the KDIGO group always look for reasons for regional differences in writing those recommendations. And actually, there's no reason to change those recommendations anywhere in the world according to the evidence we've got. Many of those studies were done in multiple different countries and in multiple different populations of patients.
And just for myself, I mean, I was just thinking through when you were showing us the data on albuminuria and the fact that the absence of the albuminuria did not seem to lead to impactful outcomes with regard to CV death and heart failure. I mean, progression of kidney disease. I think it was a primary outcome. Maybe you can just clarify. I didn't quite get that. And as you clarify that, I'm beginning to wonder, is it that the ones with microalbuminuria are more downstream and therefore are more likely to benefit within that time frame of that study? Or with the same, and with a GFR that's quite progressed down to 30, 35, if you have no microalbuminuria, are you not going to benefit? I mean, just clarify that bit.
I'm delighted to let my colleagues answer the questions, but I'll carry on if you want me to.
Yeah, just then we can.
I mean, I think the patients recruited into Empagliflozin were possibly one of the better treated groups, lower risk groups. The fact they didn't have much albuminuria means they're in a much lower risk category than the patients who had higher levels of albuminuria. If you do a meta-analysis of Credence, DAPA-CKD, and Empagliflozin, and you bring in all the kidney data from all the other 13 outcome trials, you get some very clear messages. And one of those clear messages is there is a reduction in cardiovascular death when you put patients with kidney disease onto these drugs. It just doesn't come out in all the individual trials, but you see it in the meta-analysis.
So maybe a lack of power, numbers,
with individual trials.
Because I noticed maybe the Credence studies, they had 17,000 patients, etc. I see, I get you. So maybe now we'll ask, please do, yeah. Let's give the microphone. Is there anybody with the roving mic? That's Professor Gola, cardiologist, professor of medicine, and distinguished teacher and reader, governor of the American College of Cardiology regionally. I could go on.
Please stop. Yeah, I had an issue with the interpretation of the albuminuria results. I mean, maybe purely from a statistical point of view. So here you have a study that has got a primary endpoint, which is a composite. If you look at the forest plot, when you are looking at the primary endpoint, the composite endpoint, there's heterogeneity. There doesn't seem to be any benefit in those with, especially below whichever figure you use, 200 or 20 or whatever. It gets a little better if you are in the, in quotes, microalbuminuria group. Then there's clear benefit in the macroalbuminuria group. Then you then take one of the components of the composite endpoint, which is the kidney, component, and then you take one of the components of the component, which is the decline in GFR, and then you show a positivity. Isn't that torturing data? That's my question. And just before you answer, was there an analysis using the whole kidney outcomes rather than just decline in GFR?
So I think it's a very fair question. You know, you're digging into the data to find a benefit. And I think that's what has been done there. It was a pre-specified analysis. So it was in the scientific hypothesis that the groups would be analyzed according to the level of starting albuminuria. But I think what you're saying is it's difficult to find a benefit in that patient group who had lower levels of albuminuria. The benefit that was found was a numerical benefit. It was a change in slope. But we have to remember there were so few events in that patient group. They're a very low risk group. They have so few events that it's very difficult to study them in this kind of context. So I think it's a very fair criticism of the trial. I think the message is, you know, if we've only got 20% of patients who should be on SGLT2s in the UK who should be, let's go after those who are going to gain the greatest benefit. And those are not those with no albuminuria. Those are the diabetics with huge amounts of albumin pouring out in their urine who are going to have heart attacks, strokes, heart failure, and kidney failure. And those are the low-hanging fruit. I think with scientists, we don't like the idea that there's a heterogeneity in the benefit, and that's why the group went after that difference in EGFR slope. But I think it's a valid criticism of the analysis.
So if you were given a patient with an EGFR of 30, no microalbuminuria, and they have to pick their drugs, don't have all the money.
I would be less inclined to start that patient on an SGLT2 inhibitor unless that patient said to me, give me the best treatment in the world now.
And would you be more likely to start the drug if you had diabetes, if the patient had diabetes? Sorry? Why?
I would.
Because diabetes and CKD is an indication on its own. So, I mean, when you showed the KDIGO indications, it was the first one up there. So that I have no issue with. The issue, I think we agreed, basically.
If your patient's diabetic, it's a no-brainer. You want to use a diabetes drug. Why not use one that might benefit the kidneys and the heart?
Might. We could go on and yes. Dr. Kelida Soki.
Thank you, Prof. Thank you for the excellent presentation. I mean, reading this trial was actually just a lot of fun because as nephrologists, it was confirming a lot of the things that we can say anecdotally that we were seeing, including starting these drugs on patients that had GFRs less than 20 in terms of trying to think about maintaining residual renal function for a longer time and keep them off dialysis, which we know is best for them. So thank you for that, Prof. I think Rilwan can talk about the uptake of SGLT2 inhibitors in the Kenyan market, which appears to be above a lot of other countries. I'd like Professor Boehringer to tell us how the uptake has been in his country, and we talk about lower and middle income countries, but I'm also going to ask Prof.
Okay, well, we'll come to that questions. Actually. If you give there was something that she was going to touch on, then we'll go to them. And I think the immediate question, obviously, in the setting of this arena, kidney disease in the diabetic patient, you're in a diabetes clinic. How good are we at picking kidney disease up, and how good are we at then move on to treatments that protect this patient, and how are we following up these patients to make sure that they're actually benefiting from these therapies? What's your experience with this? What can we do better? Are we doing well?
Thank you so much. So from where I'm sitting in the diabetes clinic, I think probably from my station, it's a bit biased. I'm in a eye-based hospital, so most of the patients who are coming in with a bit of retinopathy. So we tend to have a bit of a burden because of the CKD in this patient. So the microvascular complications have already started. So we're having a little bit of more of the CKD patients as well. As far as picking the CKD up is, I think we use the creatine EGFR, and at my center, it's a bit subsidized. So I know the urine albumin creatinine ratio is a bit expensive, but we tend to do it in our clinic. I know probably out there it's a bit expensive, and a lot of times people don't do it, but I think in our center, we're picking up a lot of patients who already have developed, at least they're in stage 2 or 3A or 3B. Very few we tend to pick at end stage renal disease, but we tend to get a lot of microalbuminuria as well. Well, as far as the uptake of therapy comes in terms of patients who require probably SGLT2s, and I think this is where Kalida's question comes in. I think this is mostly becoming a popular question when I'm on this panel, because I think Professor Ogola also brought this up before about the uptake of SGLT2s being very popular in our setup now. But I think we have taken it up quite well in terms of the numbers. And I think Professor Ogola put this question to me before when I was on a panel, like, are we overusing it in terms of...
That was going to be my question. Actually, to build onto that, Prof, is albuminuria enough to initiate a patient on an SGLT2. No diabetes, nothing.
Can I add to that? Lupus patients, transplant patients, ADPKD patients who might have albuminuria, might have a reduced GFR, but were largely excluded from all of these trials. What will happen to these patients?
So in all the trials except EMPA, there was a lower level of albuminuria, and that has tended to be used as the cutoff threshold for the license in the individual countries. So for example, in my country, for DAPA, we have a license that exactly reflects the inclusion criteria for the DAPA-CKD trial. So if the patient fulfills those criteria and would have got into the trial, I think it's a really easy yes. For those patients who have lesser levels of albuminuria, it's a bit of a stretch, and you have to then look at the EMPA kidney data and say, actually, you know, there were some benefits at lower levels of albuminuria. I think in diabetes, it's easy. If you've got a diabetic, they've got any signs of kidney disease, give them an SGLT2. If you've got a diabetic who needs treatment, who doesn't have any signs of kidney disease, we actually know from EMPA-REG that patients are less likely to develop even the earliest signs of albuminuria in that study of diabetic type 2 diabetics. So if you've got a patient with diabetes who doesn't have kidney disease, you might want to put them on SGLT2. The harder bit comes with those patients who have kidney disease that's not diabetic, who wouldn't have fulfilled the inclusion criteria for the trial. So, but in terms of the spectrum of patients we put in, we're putting patients with IgA nephropathy, with lupus, with FSGS, with all of the proteinuric kidney diseases. They're going onto these drugs in addition to ACEs and ARBs. We had 270 patients with IgA nephropathy in the DAPA-CKD trial who showed a very clear benefit from randomization to Empagliflozin. Empagliflozin reproduced that benefit very clearly in their analysis. Yeah.
So, Dr. Aden, do the diabetes guidelines reflect the information, say, from EMPA-REG, that any diabetes patient, the development of new kidney disease is enough to drive you to put an SGLT2 as a first-line drug, any diabetic patient, over any other drug? And that next question is, what is the risk of a diabetic patient going on to develop renal disease in their lifetime? And that's the bottom line. Yeah.
Thanks, Doc. I think it's, like you said, it's quite clear from the EMPA-REG. And I think you guys have really want to steal this drug, because if you look at EMPA-REG trial, this the glycemic control, it's still useful for glycemic control, despite the patients obviously having high risk for atherosclerotic cardiovascular disease, despite the patient being high risk kidney disease. So it's still useful in our patients who we're seeing at primary care, the diabetes management. Remember, glycemia, weight, even if not quite significant compared to the newer drugs, but as well as prevention. If you look at it and this is anecdotal, I have not published, but in the clinic you find patients who come with albuminuria, and you put these patients on this drug, and we've seen them actually, the albuminuria actually improving with time. So
I think maybe Prof. Wheeler could comment on that issue. No albuminuria, new diabetic, 40 years old or 45 years old. What are the guidelines saying in the diabetes? Yeah.
So that's out of the remit of kidney guidelines and in the remit of diabetes guidelines, because if they haven't got kidney disease, we can't be writing guidelines for them. But my logic is you're going to want to give that patient an agent to control their glycemia. You can give them a sulfonylurea, metformin, a DPP4, or an SGLT2.
And they're working very well.
If I was the patient and you said to me, I can give you a drug that lowers your sugar, or I can give you a drug that lowers your sugar and protects your kidneys and your heart in the longer term, I know which I would choose.
Remember, you also have, apart from albuminuria, you have other atherosclerotic cardiovascular disease risk factors, which this patient may be having. So the patient may not be having microalbuminuria or albuminuria for that matter, but this patient might be having hypertension. this patient might be having hyperlipidemia, this patient might be having obesity. So there are other
Yeah,
risk
there are
factors for
others, but those were
ALD.
not actually enough to get you into the EMPA-REG. In fact, almost everybody they had vascular disease, but I think I remember the parallel trial to the EMPA-REG. I forget it now, where the DAPA guys.
The clear TIMI and
Yes.
canvas.
Yeah.
The thing is, if we went strictly by the guidelines, I think that the guy with diabetes and any form of kidney disease is easy actually. DAPA CKD tells us they should all be on an SGLT2. The guys at high risk of vascular disease, either because they already have incident cardiovascular disease, or they have multiple risk factors, as was there in canvas and declared TIMI, are clear cut. I think that where the data gap is maybe the recently diagnosed young type 2 diabetic who probably is lean, may have hypertension, has got no other risk factors. So if you went strictly by the evidence, there's no evidence for that.
Nope.
But the reality in clinical practice is that there can be no randomized clinical trial for every clinical
That's very true. So, Prof, just to tie this issue up.
Let me just finish my last sentence. So I tend to use SGLT2s in those environments if it is accessible, because I have a drug that I know in a certain population, subpopulation works. I don't know very well whether it also works in this population, but I have no evidence that it causes any harm. So if we go strictly by the evidence, there's no evidence that the SGLT2s will be better than, say, metformin or a DPP4 or whatever. I'm not a diabetologist, but that's my interpretation of the data, and I would like to hear from the diabetologist.
So I'll just tie that issue up so that we can let Prof. Madi and Boehringer talk. But I think the studies don't address that question. They stop at 2.5 to 3-4 years. We're talking about a lifetime risk. This is somebody who has a significant risk of developing earlier mortality than a non-diabetic. I think that patient deserves to be considered for a drug that will delay serious morbidity. I don't think we can extrapolate from epidemiological studies. We can work backwards, and maybe, Prof, in your research institute, I think that's a very important thing to do. But maybe we can let Dr. Boehringer.
I think just to add to what Prof. Kariuki said, we are looking at Cardio-Renal-Metabolic syndrome. We are looking at all these in a spectrum. So if you see a patient with type 2 diabetes and CKD, for instance, that person is at risk of cardiovascular disease. Diabetics is an independent risk factor of ischemic heart disease. And then if you have CKD, you have increased risk of cardiovascular disease. So if you have diabetes, and probably to make a choice for an add-on in the very initial stages as a first line, I think that looking at the drug that spans the spectrum of this cardio-renal-metabolic syndrome is a reasonable choice to make.
As a first-line drug?
As a first line. If you look at the KDIGO guideline, as an add-on, it's actually at the same level as metformin. If you look at the pyramid, it's there as one of the first line. So it's a drug. It's reasonable to consider this drug in the very early stages already. And from the very last slide he showed in terms of the modeling that he showed, if the early you start this drug, the early the benefit. In fact, for those of us who work in tertiary institutions, we wait until the very late stages before the cases are referred to.
So if I may interrupt you, I'll throw a spanner in the works. I don't know if anybody has any evidence that it impacts insulin resistance. A, B, are we better off combining these two drugs because they have different modalities, the metformin and the SGLT2, get your insulin resistance sorted out. We don't see macrovascular benefits with SGLT2s. We need to address that. So I don't know if one of you can pick that issue up.
I'll just comment then, but I'll let Prof. Wheeler also take. But you see, there are approaches in terms of dealing with these patients with cardio-renal-metabolic syndrome. Are you going a linear way whereby you just go one by one, say, okay, I'll start with metformin, see how things go, maybe I'll add on and add on, or you're going to go with an approach called a pillar kind of approach, where you can start all these drugs and the benefit for it.
Like heart failure.
Precisely. So ARB, SGLT2, ANI, and then non-steroidal MRAs, etc. You're going to try to think about how to carefully combine this in the benefit in the beginning, or maybe somewhere along the line for the benefit that the patient is going to derive from it in the long time in terms of kidney protection, cardiovascular protection.
And what does a cardiologist think?
Well, most times patients who have type 2 diabetes are also regarded as coronary equivalent, and because they have maybe indolent atherosclerosis going on, and maybe of course the glycemia can damage the heart muscle. Perhaps if you start your SGL2 on time, for us from the heart failure, and it will reduce risk of incident heart failure. So if I'm seeing the diabetic, who has other cardiovascular risk factors, the person is already on ACC stage 1 heart failure. I really don't want this risk factor to affect the structure or the heart or the function as well. So although we don't have a clear mechanistic pathways for how SGL2 work, but if you leverage on the pleiotropic properties, it can impact the heart muscle very positively. So I may want to give it that.
So maybe Prof. Wheeler can arbitrate the whole point of multiple targets, the pillar approach that.
Sorry, the whole point of
the pillar approach. He's talking about
pillar approach.
Yeah.
So we've watched the cardiology heart failure pillar approach, and we're developing the same in chronic kidney disease now, particularly in diabetic kidney disease. We have 4 pillars in diabetic kidney disease. We have ACE or ARB, we have SGLT2, we have 3rd generation mineralocorticoid receptor antagonist, finerenone, and we now have, as of 2 weeks ago, data from the FLOW trial showing semaglutide was also kidney protective in patients with type 2 diabetes. And we've got some promising data coming along with aldosterone synthetase inhibitors and with the SENTANs, the endothelin receptor antagonist. So that's an awful lot. But what I'm saying is we've gone from ACEs and ARBs, which we learned about 20 years ago, to potentially having 5 or 6 pillars of therapy for chronic kidney disease, particularly diabetic chronic kidney disease.
So the diabetics need to join the party and start a pillar approach. That was the whole point. So I think that was a bit of a tough question.
Can I comment on something?
How should we work with nephrologists? Should you refer everybody at physician level, diabetes level, who has a bit of microalbuminuria? Should they all see a nephrologist?
Well, I think most of the guidelines actually talk about EGFR. I think stage 3, from stage 3, 3B, I think to 4,
So you
5.
wait for them to get there. I mean, maybe, where is she? Soki walked out. Should they send everybody?
And also at least with albuminuria, obviously. But we have these drugs which we're giving and we're following up. But the best approach, I think, is actually a multidisciplinary approach if you co-manage with the nephrologist. But again, in our setup, we may not have as many nephrologists.
Yeah, then hard to access, but they should give us guidelines really beyond their camp. I mean, you have your small little groups and meetings, but I think they should disseminate this information more widely. I think the issue is confidence amongst the physicians to initiate these treatments, to label a patient as CKD. So I don't know how we can, at the community of doctors level, get us to be sensitive to this diagnosis, get us to get onto that treatment bandwagon quickly and be able to assess these patients correctly. I think at a personal level, that seems to be my main problem. Prof, you want to say something? Yeah. Wait, there was a question.
So I was trying to say, I think that the referral system is a good thing, yes, but more so is a collaborative kind of care for the patient. So if she sees a patient, she can easily call a nephrologist and discuss this patient. That how's the best way forward in terms of managing this patient, evidence-based practice, so they can apply the guidelines to as best as possible to make sure that this patient is on the drugs that really can delay progression in long term. Like I said, where Soki and I sit right now, we're going to come to us in stage 4 already. That's not what we want to see, because that time you're only going to probably slow down progression for say 2-3 years. But if it comes early, or if it's caught early at primary care level,
Yeah.
for instance, you can delay progression for a much longer time.
That's very, very good.
Yes.
Just before your question, Dr. Christian. So, Prof. Wheeler, how many minutes does a GP have in the UK to see a patient? Is it 6 minutes?
10 or 15 minutes, yeah,
Max.
for a normal appointment.
They have enough time to do all that? Sorry, there was
I
one
have a-
question there, then we get to you. Yeah.
Thank you very much, Prof. and the panelists. I'm Dr. Christian Morgan, I'm an endocrinologist practicing in Kisumu. I've been having this pertinent question. I'm happy to this opportunity to ask. Prof, especially after the presentation, we noticed that in this trial, empagliflozin didn't have an effect on cardiovascular in terms of risk. And your explanation was that because you felt the trial was short, and also most of the patients, they didn't have cardiovascular disease, but CKD patients, the biggest risk, CKD is also a risk factor for cardiovascular death. It is apart from the traditional, it has CKD specific cardiovascular risk factors. So now, when I looked at the EMPA-REF, the trial lasted 3.5 years, and we got significant benefits. But now, EMPA-CKD is lasting 2 years, just 1 year difference. Could that explain why empagliflozin did not confer benefits towards cardiovascular profile or risk compared to the EMPA-REF? So that I think we will need to get more explanations why it benefited, it performed better in EMPA-REF. And because in terms of duration, I don't think 2 years and 1 and 3.5 is enough to explain this difference. The second burning issue is DCCT trial, 1993, was the first trial that showed that if we do intensive glycemic control, we don't really have impact on macrovascular risk factors, the MI, the stroke. Other trials, some have showed benefit, it can reduce risk of stroke, MI, others not. And I've seen some meta-regression studies that have shown that glycemic control doesn't really impair the risk, macrovascular risk. And now MI is a significant.
So maybe just shorten the question a little bit.
What I'm saying is that if this trial is showing that empagliflozin is not conferring cardiovascular benefit, could it be that actually treating glycemia and with our drugs, SGLT2s may in the long run, when we use it over the long, may still show that it's not all patients that may benefit, because I've always felt, oh, this is the wonder drug. This is the first drug that even.
Okay, I think we got the question. He actually had part answered it. I don't know. We can talk about that. By the way, that's a huge issue, which we can talk about all night, but maybe you can summarize the issue of the cardiovascular benefits. And I think a little bit of the definition of CV death and mortality to see coming in, and how long it takes to get all these outcomes.
So I think very important points. So I was at as I say, our UK kidney meeting. We had a presentation from the CKD Prognosis Consortium group from Johns Hopkins, and they showed the latest data they've got from the CKD Prognosis Consortium. If you're a patient with CKD stage 3, you are 15 times more likely to die of a cardiovascular event than end up on a dialysis machine. So we have to remember the priority in all of these patients is managing cardiovascular risk. These drugs, I think, manage the heart failure risk, but they do not manage the atherosclerotic risk in quite the same way as other drugs do. We did in Credence see a 20% reduction in major adverse cardiac events, but we haven't seen that. We have to remember blood pressure, we have to remember statins, we have to remember all of those cardiovascular protective therapies, and we've got to get that right, as well as getting this bit, the kidney failure bit right. So I don't think we can look upon these drugs as necessarily the drugs to reduce atherosclerotic cardiovascular risk. But if your heart disease is due to heart failure, as it is in many of these patients, then these are the right drugs. But they don't unblock coronary arteries.
I think that's a question that really needs to be answered. Just to mention very briefly, the UK PDS did show that macrovascular benefit, but I think that's partly, in my view, because it modifies insulin resistance. You're not touching insulin resistance with the SGLT2s, neither are you with insulin therapy. In fact, if anything, you're not helping, and DPP4s are not.
So I think a lot of the treatments for diabetes, very few will impact the hormonal systems that go on to develop MI strokes. You will impact heart failure because of the mechanism of the SGLT2 in terms, reducing and contracting volumes and, intravascular volumes. And so that's my theory. So I think until we get the insulin resistance issue sorted out, you're not going to get benefit from strokes, MIs. The other issue is that these guys are very well treated. If you look at the EMPA-REG outcomes in the placebo groups and the outcomes in the trials now on placebo groups, they're very different. I think the mortalities have come down. MI mortalities have come down in all trials from initial 13%, 9%, 6%. And now we're now having something like, in-hospital outcomes, 3% in-hospital deaths. So I think that may also be a factor. But I think it's not going to be easy to show MI stroke benefit with drugs that don't impact insulin resistance. That's my view. Yes. Yeah.
There is actually a meta-analysis in circulation, I think it came out early this week, that looks at all the SGLT2 trials across all the patient groups, the initial diabetes studies, then the heart failure studies, then all the kidney studies. So total population about 76,000. And they focus specifically on MACE, traditional 3-point MACE, cardiovascular death, stroke, and MI. So if you look at the MACE in total, there's a modest reduction. Definitely statistically significant, but not very high. Now, that MACE reduction is purely driven by cardiovascular death. There was a non-significant reduction in MI and absolutely no reduction in stroke. So it reinforces the point that came out of the earlier diabetes studies that SGLT2 inhibitors don't impact atherosclerotic events much.
That's absolutely correct. I think even the meta-analysis by Butler the other day didn't show, despite them putting together, I think it was over 100,000 patients. So there was a question here. Yeah.
No, I think Prof read my mind is the same. It's called the SMART-C meta-analysis trial, which they analyzed almost 90,000 patients just to look at if they are going to see any benefits in renal and cardiovascular outcomes. Of course, as Prof said, is correctly, the adverse effects on stroke, MI
were not impacted. And hence my question of whether you should be combining drugs that impact insulin resistance with the SGLT2. Yeah, thank you. Okay, did we have any other questions from the audience? So you were asking when patients should start seeing you. Is it when we imagine they will get microalbuminuria in the next 1 year, or?
The thing is, when you risk stratify your patient, you can't just look at them in terms of microalbuminuria, isn't it? Because more and more the pathogenesis of diabetes is coming out as something totally very different, looking into oxidative stress, looking into fibrosis, resulting in now myocardial injury, resulting in podocytopathies. It's not just the fact that what does albuminuria signify, maybe is intraglomerular pressures, but there's so much more going on in the kidney and in the heart. So when you refer to a nephrologist, though I think we'll soon be out of a job if you consider the FLOW trial and finerenone and all of those, and I hope we will be. But when you send to a nephrologist and send early for a risk stratification in terms of looking at the patient globally and what else could be affecting renal function, not just looking at microalbuminuria. So we would like to get our patients earlier, yes.
Who wouldn't,
definitely not. Do not send to us to dialyze, please. Which is
so
what tends to happen.
I'll just change tack to I'll come back to Professor Boehringer very strongly, but just to go on the cardiac side, what are the cardiac benefits?
Well, SGL2, inhibitors, came handy. Now after before ANI came aboard, there was a lull in the heart failure medicines. We didn't have any heart failure, any smart medicines that affected outcome beyond the ACE or ARBs. Now, when you see the SGLT inhibitors have come to redefine practice, they all have class 1 recommendation for heart failure, both for reduced ejection fraction heart failure and preserve them. And the mechanisms, that impact these benefits, I mean, nobody can say exactly what they are, but the SGLT does have a lot of pleiotropic, properties on the myocardial level. They protect the myocardium, improve energy, myocardial energetics.
The theories are sound. That's true. But then why were the trials negative for acute MI? Or were they negative? I don't know. Yes.
Well, it's a little bit complex to analyze. I mean, to speak on the outcome of the impact MI trial. We're looking forward to maybe a very good outcome. Maybe because just like we said, with respect to atherosclerotic cardiovascular disease, the SGLT2 inhibitors are not so very strong in that space at the moment, or rather, we don't have so much mechanistic evidence that they can impact coronary artery disease, although they are said to improve endothelial dysfunction. Perhaps that may explain why.
I think it's, yeah, I agree. It's a bit complex in my view, and I think it's shared by others. The MI patient is just like the acute heart failure patient is quite complex. It's got a bit more inflammation going on, myocardial stunning that you're not going to impact quickly just with a drug. And I think you're dependent on revascularizing these people.
Exactly, yeah.
And already I think the background treatments that we have, and I suspect in the Paradise MI, where the sacubitril valsartan didn't show much benefit on top of the ACE inhibitors, it was probably similar consideration. So I think there was some first hospitalization benefit in these patients, but I suspect that was in patients who were going to get heart failure. The ones who weren't going to get heart failure also got SGLT2s because they had an MI. So you have to think who deserves the SGLT2 in the post-MI situation. Not all of them go into heart failure hospitalization as an endpoint, or it doesn't. So I think that is my own view. Maybe the selection may not be right, and it's maybe a difficult population. That does not negate the fact that the SGLT2s, in my opinion, work. I just prescribed them this morning for a post-MI patient without any guilt. Any questions? Before we come, yes, please.
But I have a question for the nephrologist. Now, in cardiology, time is muscle. I assume also, time is also nephron. So, are there plans or programs or proposals, to upskill, the family physicians, the primary care physicians, to identify CKD risk very early and refer? In Nigeria, we have started a pilot which has become, for GPs. Periodically, we train them on how to diagnose heart failure, how to clinical diagnosis investigations, and how to institute, the guideline recommended therapies before, passing up to the cardiologist. Perhaps such a program will enable the GPs who see most of these patients, pick up the problems early enough, pass up to you before they end up with stage 4.
Yeah.
Thank you very much, Prof. In fact, we actually now do a program because the gap is too big. You cannot have every patient waiting to reach a cardiologist or a nephrologist to be started on this medication. So what we decided to change here is, the word is CKD, and we always thought it's chronic kidney disease, but the actual word is C is for cardiac, K is for kidney, and D is for diabetes. So we need to look at each patient who you put them on the hot map and you classify them as CKD stage 1, 2, 3, 4. Those patients need to be started. And that's why the reason we are having these forums is everyone should be at a level platform where you can feel safe to start an SGLT2 without referring this patient. There is a limit where we'll tell you you need to refer. I think this will be a discussion for tomorrow then. Thank you.
So maybe would simplified guidelines help, where these are the clear patients that you start on? Very simplified, single page to GPs who really don't have the time maybe to read everything. Remember, they're treating everything.
Completely. So there is a heat map which we'll put tomorrow for you to actually see who do you review after every month, who do you review in 3 months, who do you refer on arrival. So it is one single page. You can have it in your clinic and you just need to refer to it.
Yeah, thank you. That would be very useful.
Actually, I'm going to comment on that question. I think it's a very important question. One of the reasons why PCPs or primary care physicians may not refer patients early is early understanding of the clinical trials and interpretation of the data that's before them. So simplifying these in guidelines, national or local guidelines, I think is one of the ways to go. And the information should be presented such that it's relevant to each level of care and easier for them to understand. There are visual representations where you can have, for instance, visual abstracts just for one page or one slide, and then this can be left in strategic places like the clinic where he talked about, so they can have access to it. We have started a program in Ghana. We currently recently developed a national CKD protocol for that reason, and we provided information relevant to each level of care for the primary care physician, secondary, all the way to tertiary, so that at least they would be able to know when to start these drugs, when to refer the patient.
So you have some kind of guideline. Do we have a guideline in Kenya, I wonder? So do we have any guidelines?
We just launched it last week with Ministry of Health. And I think it's just something similar. We decided to do a flowchart tutorial so that it's easy to follow as well. So the updated guidelines was just, I think it's now it was out from today. So I think it's been shared in the various
And I think beyond that, we need to I was waiting for, Soki looked down when I asked her, but the dissemination of information and the confidence that the public should have and the PCPs should have with their specialists is very, very important. They need to trust that we are giving them the right, unbiased, well-sieved. I had to be reading the Times newspaper, the UK newspaper this morning. I came across it. And on page 3 was a breakdown of the semaglutide studies, along with somebody who had hijacked somebody else. But they gave a breakdown. They almost gave the p-values, explained the drug, its benefits, in which population that you give this. And this was for any reader. This was for the public to read. And my patient called me, who also reads the newspaper this afternoon, and said, look, I'm about 120 kilos. I want semaglutide because I don't want to get kidney problems. My kidneys are a little dodgy. How can I refuse to consider his request? Do you understand what I'm saying? So I think disseminating science and distilling it so that people can then look it up and see, what do our people think, our specialists think, I think is something that we should do. How we'll do that, I'm no expert. There was a question.
Just on that.
Yes.
I think I agree with you on the dissemination, and that's what we've been discussing. And this is where technology comes in. I think we don't leverage technology enough.
That's you.
We don't leverage technology enough, as well as our management, our practices, as well as cross referrals and all that. If you could see me putting down the albumin levels of my patients, you should be able, as the nephrologist or cardiologist, to be able to see it in real time on your end, so that when this patient comes to you, you have all this data, and the patient doesn't have to walk around with files and papers, and we tend to lose a lot and mismanage based on this. So let's leverage technology.
I agree 100%. I mean, if you look at the reports that come out of some of the units in Europe, there's even color coding. The patient tells you, my kidneys are showing red. There's a problem there. Those are questions, I think. So, let's start with the gentleman at the far end first. Yeah.
Okay.
Yeah, there's a gentleman there at the back. Let him finish then. Yeah. Want you asking a question? I think yes.
Okay. My knowledge is limited. I'm a registrar, so just as a okay. This is question that was just ringing through my mind, and now I think that's come up, like people are discussing that there's no proper guideline of when, like, to start, when to stop. But then, so what was going through my mind was, if we are putting these drugs on patients for diabetes, heart failure, and CKD, at what point do we say that, and the primary level of action of these drugs are the kidney level, maybe for the diabetes and the kidneys, the heart may be probably different. So at what level do we say, at this level of EGFR, we are giving for heart failure, for a patient who has got all the three? At this level, we are giving it for the heart and not the kidney. At this level for the kidney, at this level for,
I think
diabetes. That is one question that I wanted to.
Maybe we'll answer that
ask.
just to give him another
Okay.
chance to ask. I think if you attend tomorrow's sessions,
Okay.
my colleagues are going to address all these issues, and Prof will maybe arbitrate. In fact, he will be arbitrating. That's true. Yeah. Go ahead, Prof. Yeah. Yeah. But that's the message we've given them. You know, we are fragmenting care, and that's why I was trying to bring it all together at the beginning of this session. That
So tomorrow we're having the Cardio-Kidney-Metabolic Symposium. The essence of that is to show that this thing is one thing. So you don't treat a kidney, you don't treat a heart or a brain. You treat an individual with kidney problem with all its ramifications across the body, or an individual who comes with a heart failure with all its ramifications, including the
So if you use the Euroscore for cardiovascular death prediction, mortality prediction, would you think a high score on the Euroscore, which doesn't have, for example, even diabetes, would that guide you towards putting SGLT2 at the highest levels of risk? Sorry, that's another discussion for another day, but let's
that's
think
another
about
discussion. And I mean, SGLT2s are great drugs. You know, like I said the other day, you know, Brownwald calls them statins of the 21st century. But there's no magic bullet in medicine. And I think Prof said it very well, you know, earlier on. SGLT2 is not going to sort out all your diabetes problems, all your kidney problems, or all your heart failure problems. You have to look at it in context.
Good. Yeah, thank you.
Yeah, thank you very much, Dr. Manuto from Kitale. I just wanted to know, we have completely fragmented this patient, diabetes, heart. I think one of the panelists is a psychologist, and I'm just wondering at what point—
side hustle.
Yeah. At what point do we start discussing issues of chronic kidney disease with the patients? Their psychological issues. We know it's very good evidence, even multidisciplinary teams in heart failure include psychologists and psychological, assessment and discussing. In chronic kidney disease, do we do this?
I think you've now deviated from the discussion, Brad. Every chronic illness would bring psychological issues, long-standing diabetes with drugs, multiple medications over time. People get disturbed and they are at risk of mental problem. Hypertension, the same. Heart failure, the same. Of course, kidney disease, the same. And the more comorbid conditions you have, the more likely you are to develop psychological conditions. So counseling patients regarding their conditions is not limited to only chronic kidney disease. All chronic illnesses ideally should have some form of counseling regarding their condition, what they are going to be going through in terms of medication, and what to expect for them to understand what they are into so they can cope with it over time. They have to develop coping skills. They have to develop some level of resilience to stand with this condition over time. So there is counseling needed for all these category of people, not only limited to chronic kidney disease. Okay, Prof.
Okay. What he said is true. Even in heart failure, we looked at the psychological problems of heart failure patients, and we have, I think, Professor Malcolm and I, we had some publications in that direction. Most heart failure patients suffer from subtle depression to clinical depression. Most of them have anxiety problems, and it stands to reason the morbidity of the illness, the fact that they're not going to fully recover and recover back into their pre-illness life weighs them badly. Some of them are breadwinners of their homes before they took ill, and they can't do any of those. So they are subject to psychological problems. And that led to our having a heart failure psychiatric liaison in my center, where for patients who have heart failure and all that, we ask them to see the clinical psychologist. Sometimes they see the psychiatrist, at least to provide counseling. Sometimes they're also medicated with those drugs they use in improving the mood. We are still looking at the outcome of that collaboration with the psychiatrist.
I think
That's excellent. You know, I'm trying to remember the last time I sent a patient to a clinical psychologist was not going crazy. You know, we shouldn't wait for them to get to that point. I think we should do more, particularly in the private sector. We are not good at that. And maybe Kelida, you don't wait until you're counseling for transplant. I think we need to counsel our heart failure patients earlier, educate them. And it starts with educating, empowering them with this information I'm talking about, showing the benefits of treatments, modern treatments. Maybe then I'll ask Prof. Wheeler one or two questions before we start. The dialysis patient and the SGLT2, do we have any data on this? And also in the post-transplant patient, what experience do we have?
So in these trials, the drug did not get stopped during the trial if eGFR dropped below 20, for example, in Empagliflozin, or 25 in DAPA-CKD. So we have experience of patients who progressed to dialysis whilst in the study, randomized to either the study drug or placebo. If you look at those patients, you can see no adverse safety signals all the way down to needing dialysis.
On dialysis.
On dialysis, these patients continued their drug. There were no adverse safety signals. Now, whether these drugs were beneficial is a different matter, and whether these drugs can be beneficial when there's virtually no kidney function, because I believe is a great question. There is a trial ongoing in the Netherlands and Germany, and hopefully soon in the UK, recruiting patients who didn't get into these trials. So eGFRs of less than 20, including dialysis patients and kidney transplant recipients. We do not have randomized controlled trials in kidney transplant recipients. We have some pretty good observational studies that have matched patients according to their demographics, what we call propensity score matching, which suggests that there may be a benefit, but we don't have the randomized evidence from a trial, and there could be harms in terms of opportunistic infections.
And the benefits are in what kind
well,
of,
in the observational studies, the benefits are, as you would expect, heart failure, slowing eGFR decline, less likely to restart dialysis, but it's observational.
On dialysis, on dialysis.
No, this is kidney transplant recipients. We have the observational data in the dialysis population is from these trials, the few patients who ended up on dialysis during the trials.
So on the kidney transplant, sorry, I missed that.
Kidney transplant.
There is a trend that's being seen towards benefit.
The trial will include dialysis patients and kidney transplant recipients.
I get you. Yeah, good. Sure.
I think recently, in collaboration with the cardiologists, we decided to start one patient in Ghana on SGLT2 is on dialysis. And this is a patient who had a previous stent, 2 stents. I think the third one, they were going in for the third one. They realized they couldn't do it because there were multiple. So he called me on the phone and said, "Oh, can we start this person on that part?" Okay, I said, "Okay, let's just start. I'll monitor the patient." So I have been monitoring this patient so far. There's no problem in terms of adverse event, but we realized that he's been stable for the past 4 or 5 months, and then I sent him back to the cardiologist to repeat the echocardiogram. So currently his ejection fraction stood around 37. Initially it was 35. I'm not sure whether it is the SGLT2, but I would say this patient feels fine and tells me he feels much better. So we are still observing this patient in the long term to see if what the outcomes would be. I'm not sure whether I can clearly attribute the drug to it, but that is what we've seen. Yes.
Yeah, there was a question, I think.
Yeah. Okay. As our nephrologists start writing the guidelines, now I was just wondering that we have a bit of difficulty in CKD. Now, the biomarkers for CKD I have not heard being done in many places, like NGAL and strategy. In South Africa, they do routinely, but here our machines are able to do it. But I have not seen any request from our nephrologists to see that whether we can do that one. So can it help to stratify the patients, and our GPs can help it out that what level can we refer to the nephrologist?
Maybe we can get to a local nephrologist to answer that question. You've been asked to. Anything on the cystatin? Did you hear the question?
Yeah, the question is right, actually. The biomarkers are not very accurate. In fact, if you look at last month, there was a trial which came out justifying that cystatin even will not give you an accurate measurement. And NGAL will actually be affected with the level of your kidney injury, which is the,
And do we have any outcome studies, big outcome studies that impact outcomes in these molecules, in these tests?
No.
No. If they don't have outcome studies, we are unlikely to justify the cost
we don't
of
have.
disseminating.
In fact, the only trials which have been done were actually from the animal model, and one was done in human using the Empagliflozin to look at the inflammatory markers of interleukin-6, which was measured before giving SGLT2 and after SGLT2, and there was reduction of the inflammatory markers, giving you an added advantage of the erythropoiesis because of reduction of myelofibrosis in the area of macula densa. So we don't have complete data. Yeah, we don't have.
Okay, good. Are you using them in the UK at all?
So in the UK, we struggle to measure albuminuria in primary care.
Leave alone cystatin.
Let alone cystatin C. And in fact, our laboratories, when you ask them, don't do cystatin C, even though the new KDIGO guideline has recommended cystatin C, particularly in that borderline zone around 60 ml per minute, when you really want to know whether it's CKD or not. But our labs are not doing it. It's expensive. We just focus on EGFR and UACR and getting the urine done.
Good. Thank you. Well, any comments from the panel? We might ask the BI group to come and take us through some. Yes, go ahead.
So is that the last comment?
Well.
Okay, just want to be sure before I make my comment.
Okay.
So I think, well, just like Prof said earlier on, there's no doubt that SGLT2 has evidence in terms of cardiac and kidney protection. Just like he said, again, we are not looking at one organ. We are now looking at three things: type 2 diabetes, we are looking at heart disease, and we are looking at kidney disease, and we are treating the patient as such. So we need to risk profile the patient, put them in context, and decide whether they're going to benefit from this drug. And the earlier we start this medication, the earlier we give them more time than when we start late. And just like everybody said, we need to bridge a gap between those of us in the tertiary institutions and those at the front line of care, so we can start treatment early for these patients in order to give them more time. Thank you.
Thank you. Thank you very much. Doc?
Thank you. So as for me, obviously, I'm a strong proponent of starting this molecule quite early because of the benefits, the pleiotropic benefits and all that for our type 2 diabetes patients. And I think I want to caution, Prof had mentioned that the lean type 2 patients, we need to be careful with these patients. I think there is some studies out of Uganda with London School of Hygiene that came out that showed that a lot of our population, the younger, I think 30 to 40-year-olds who are lean with type 2 diabetes, they tend to have more of an insulin secretion problem as the main pathogenesis of type 2 diabetes. And so we need to be careful with these patients because they're the ones who develop the euglycemic decay. And another question is probably the glucotoxic patients, the patients you initially diagnose very high. These I've not, I think as Prof said, the safety profile is quite good, but these are the patients who tend to develop the genital mycotic infections. And so a lot of these patients, when you put them on it at the initial glucotoxic stage, they tend to get this and then they're put off the drug.
So you
because
control
of this.
first.
Yes, so just control the glucotoxicity, probably with a bit of insulin, and then put them on it so that they gain the benefit, because we find a lot of them being stopped because of the mycotic infections that they develop. So that's it from me. Thank you.
And Prof, maybe your last comments after you've listened carefully to...
Yeah, I wanted to go back to our registrar's comment, but he's not left the room. It was really good to have a registrar here contributing to this discussion, because I think these guys are going to be using these drugs far more. But I think I wanted to just turn that around and suggest that it's not what organ are you treating, it's what is your excuse to start the patient on this drug. You've got a patient with cardio-metabolic renal disease, they've got diabetes, they're going to probably develop some kidney damage and some heart failure. Find the excuse to put the patient onto the drug, be that for heart failure or kidney failure or diabetes, because you're protecting then all the organs. So switch it around and find the excuse, the reason to use the drug based on one organ system or one specialty, whichever specialty you happen to be.
So maybe, Prof, the last question is the non-diabetic multiple risk factor patient without organ dysfunction. Would you consider an SGLT2?
The non-diabetic patient with organ dysfunction.
Multiple risk factors. I've thrown that question to
Myocardial
him.
infarction. Well,
No, multiple risk factors.
Multiple risk factors.
I'm asking Professor Gola. He's a reader.
I'll give him a microphone.
With a 25% 10-year risk of mortality.
So normal HbA1c, no diabetes, that is.
Smokes.
Okay.
Hypertension.
Yes.
Dyslipidemia, LDL more than 5.
Not in heart failure, whether it is middle.
No.
Okay.
Is a stage B though with that?
No evidence currently.
Yeah, there's no evidence. But
Yeah.
so you would not start because there's no evidence.
I would not.
But you'd follow him closely.
Yes.
So that you don't just tell him there's no evidence. You'd bring him in every 6 months.
Yes.
And the moment you see microalbuminuria or an HbA1c that's up.
Yes. And saying that no evidence for SGLT2 does not mean doing nothing.
Yes.
There's still a lot
correct.
that you can
That's
do.
a point. Okay, thank you very much. I think we've enjoyed this session very much. There'll be more tomorrow. We'll ask the Boehringer team to come and take us through the rest of the night. Thank you.
Thank you very much, Dr. Kariuki. Please join me again in giving first our moderator a very big applause for his very good job, as well as our speaker, Professor David Wheeler from the UK, and our amazing panelists, Professor Boehringer from Ghana, Dr. Kasmi Ramadi from Nigeria, and of course, our very own Dr. Rilwan Adan from Kenya. I don't know if I'm the only one, Prof, you're welcome to sit, yes. I don't know if I'm the only one who felt a little bit relieved when Prof Wheeler said that they also struggled to test albuminuria in the UK. Okay, so this shows that our challenges are similar all through the world, not just in Africa and Sub-Saharan Africa where we are. As we come to the close of this Cardio-Renal-Metabolic Summit, it is my humble and honorable, I'm very honored to speak on behalf of the Boehringer Ingelheim medical team to say a huge thank you to all the participants who took their time away from a very amazing Friday evening to come and be with us. And the online participants who've joined from Ghana and Nigeria. I have heard that we've had about 400 participants from those regions, as well as others from right here in Kenya. We really, really appreciate taking the time to come and be with us. As I welcome you to have dinner, and as we come to the close, this was a CPD accredited event by Kenya Association of Physicians. As you step out, you may pick your CPD points from the registration desk, as well as your certificates of attendance for this event at the registration desk. And maybe just as I close, it's been a very interesting and very insightful participation and discussions. And it just reminded me of the story of Napoleon. I'm sure you guys know about Napoleon, who was a mighty leader. And he wouldn't go into any war until he meticulously planned, until he knew the terrains, until he knew if he had enough logistics, until he knew everything. And when he went in, he was assured that he was going to win. And of course, he won majority of his wars. So here we are faced with a huge war, which is cardio-renal-metabolic disease. Do we have everything we need? Do we have our tools? I feel like maybe Prof. Ogola and majority of you participants are like, let me call him Dr. Napoleon. You're very careful before you go in, but maybe something to think about. We are faced by a very huge war. Are we going in? Are we still planning out here? I don't have the answer. It was just a thought. Now it is my honor to invite you all for dinner. There will be some soup served from this side before you proceed for the main meal. And as we close, I would like to wish our Muslim brothers and sisters a happy Eid. I hope that's how we say it. And to thank you all very much for giving us a public holiday on Monday. Have a good evening. Just one more announcement. Tonight's event was just the first of 2 meetings. You are welcome to tomorrow's meeting. We have a robust agenda planned. Those who are online and you would wish to come, the meeting starts at 9 a.m. right here at Serena at Alamanda Room from 9 a.m. all the way to 1 p.m. You're welcome.